Good day, everyone. I am Dr. Kristian Rubiano, and today I have prepared a basic instructional video on basic pediatric 2D echocardiogram. As mentioned, this video will only cover basic what to do's in doing 2D echocardiogram, including how to do different echo views and how to measure structures and Doppler signals. Before doing or requesting a 2D echo, a clinician must thoroughly evaluate the patient through thorough history and physical examination, and further requesting for other ancillary tests such as chest radiographs, ECGs to correlate their findings and make an initial impression before requesting for a 2D echo. 2D echocardiogram, also known as cardiac ultrasound, is a non-invasive procedure that uses high-frequency sound waves to create real-time images of the heart. A 2D echocardiogram can show the heart structure, function, and motion, including the valves, chambers, and blood vessels. It can also detect shunting of blood, as in cases of congenital heart diseases. Also, it can be useful in the evaluation of ventricular wall motions. In pediatric patients, it is important that a pediatric cardiologist would perform the 2D echocardiogram since majority of the concerns in the pediatric population would necessitate thorough evaluation to consider or even rule out a possible congenital heart disease. Because of this, it is needed that an in-depth examination will be done to examine cardiac anatomical structures. In performing a 2D echo in a pediatric patient, it is a must that it is done when the patient is calm and in a comfortable position. The echocardiographer is ideally be on the right side of the patient. But in cases wherein there are a lot of contraptions or machines beside the patient, it may be done on any side that is feasible depending on the examiner's preference. Before doing the procedure, the echocardiographer must identify his or herself to create rapport. We need to explain briefly the procedure to the parent or guardian and to the patient, especially in older children. As mentioned, we need to place the patient in a comfortable position. You may opt to use toys, musical instruments, or even gadgets to somehow distract or calm down some patients. In some combative patients, we may give some form of sedation if all else fail. In most of the views that we will discuss, we will be talking a lot about the orientation of the views. It is important that the echocardiographer would have a good concept of the use of the ultrasound probe and its marker. The ultrasound marker is a small, often colored or patterned indicator that denotes the orientation of the probe during imaging. By using the index marker, practitioners can maintain consistency in imaging protocols, ensuring that everyone interprets the images in a standardized way. In this video, we will be talking about the probe marker in relation to clock face terminology to indicate the orientation of the probe. These are the different standard transthoracic echocardiographic windows where we place our echo probe, namely subcostal, parasternal, apical, and suprasternal windows. In some cases, like in dextrocardia, we may need to use the right parasternal and right apical windows as well. To start, it is ideal for pediatric patients to start with a subcostal or subxiphoid view because it is a valuable position for assessing various cardiac structures and functions. It is particularly advantageous due to its ability to provide information about both the heart and surrounding vessels. Subcostal view can give us a great view on right atrium and right ventricle, aiding the assessment of size, function, and presence of any masses or thrombi. Next is the inferior vena cava, where we can measure for the size and collapsibility, which helps assess right atrial pressure. Evaluation of IVC diameter and its respiratory variations can offer insights into fluid status and right heart function. Also, the IVC connection in the right atrium can be best seen in this view. Next is the pulmonary veins. This view can visualize the entrance of pulmonary veins into the left atrium, which is crucial for detecting anomalous pulmonary venous connections. Next is atrial septum. It is useful for assessing the atrial septum, including the size and presence of any septal defects, like in cases of patent foramen ovale or atrial septal defects. Next is pericardial effusions. The subcostal view is excellent for identifying pericardial effusions, as fluid can accumulate in the subxiphoid space and can be visualized easily. Also, this view can be useful when doing echo-guided pericardiocentesis. Next is left atrium. While less optimal than other views, the left atrium can still be assessed for size and morphology. Next is valvular function. Although primarily focused on chambers and vessels, this view can provide information about the tricuspid and mitral valves in terms of appearance and function. Next is septal motion. The motion of the interventricular septum can be evaluated, which is helpful in diagnosing conditions like right ventricular pressure overload or left ventricular dysfunction. To do this view, bigger kids would need to flex their knees to relax the abdominal muscles and some breathing techniques for better visualization of the subcostal area. The probe is placed on the subxiphoid area, angulated upward, tail down to view the cardiac structures. In most cases, most especially in bigger children and adolescents, this view may be very uncomfortable since it entails pressure in the subxiphoid area. Hence, it is important to create rapport during the procedure. If not feasible to perform subxiphoid view, we may opt to do it at a later time when the patient is more comfortable. We initially place the probe perpendicular to the vertebral column with index marker at the 3 o'clock position. Ideally, we need to do real-time video or B or brightness mode. But since subcostal view is sometimes uncomfortable, we use simultaneous B mode and color compare for this video. We need to visualize the IVC, aorta, in relation to the vertebral column, liver, and the stomach by tilting the probe left and right. In this image, the blue one is the IVC or the inferior vena cava, and the red one is the aorta. In color Doppler imaging, color blue represents blood flow moving away from the transducer probe, while red represents blood flow moving towards the transducer probe. To remember this, take note of the acronym BART or BART, meaning blue away and red towards, signifying blood flow away or towards the transducer probe. We will again emphasize this as we go along the other views with color Doppler imaging. From the 3 o'clock position, we turn the probe marker to 12 o'clock position to visualize the great vessels in longitudinal or parallel view. In this view, we can see the connection of the IVC to the right atrium. Also note the connection of the hepatic vein and the inferior vena cava as it enters the right atrium. To show the aorta, we may slightly sweep or tilt probe medially with index marker still at 12 o'clock position. We need to measure the descending aorta and the IVC. We can measure the IVC collapsibility. IVC collapsibility refers to the respiratory variation in the diameter of the inferior vena cava, which can be an important indicator of right atrial pressure and overall fluid status in a patient. The proper measurement of the IVC is crucial in the evaluation of the IVC and its collapsibility. The IVC is measured just below the diaphragm, approximately 1 to 2 centimeters from where it enters the right atrium. Then do M mode. Measure the IVC with widest during expiration and narrowest during inspiration. Calculate the IVC collapsibility by getting the widest, subtracting with the narrowest, then divided by the widest, multiply by 100 to get the percentage. Normal IVC collapsibility is greater than or equal to 50%. Next would be subcostal long axis view. To do this, place the probe below the subxiphoid process with index marker at the 3 o'clock position. Angulate towards the left shoulder. Move the tail gradually, tail up to tail down. The structures that are visualized in the subcostal long axis view are the following: right atrium, tricuspid valve, right ventricle, interventricular septum, left atrium, left ventricle, mitral valve, aortic valve and ascending aorta, and pulmonary artery. In the subcostal short axis view, still at the subxiphoid area with the index marker at approximately 5 o'clock position, this view is obtained by placing the ultrasound transducer just below the subxiphoid process, tail down, and is angled towards the right shoulder, then tilting leftward. Here's what we can typically see in this view: the left ventricle, right ventricle, interventricular septum, papillary muscles, the valves, specifically tricuspid and mitral, aortic valve, left atrial appendage, and inferior vena cava. Next is the parasternal long axis view, or what we call plaques. Plaques is obtained by positioning the ultrasound transducer along the left sternal border, typically at the third or fourth or even fifth intercostal space, depending on the cardiac size, with the index marker at the 9 to 11 o'clock position, ensuring that you visualize the parallel axis of the aorta. It may be lower in patients with cardiomegaly and may even be done on the right parasternal line in cases of dextrocardia. This clock phase terminology is not absolute, since each and every heart is different from each other. Hence, we may need to tilt, rotate, or even swipe accordingly to visualize the structure of interest. The structures visualized in the parasternal long axis view are the following: left ventricle, left atrium, mitral valve, interventricular septum, right ventricle, aortic valve, ascending aorta, pulmonary artery. The parasternal long axis view is vital for various clinical assessments, including evaluating left ventricular size and function, assessing for hypertrophy or heart failure, assessing mitral valve, checking for mitral regurgitation or stenosis, detecting for structural abnormalities such as left atrial enlargement, septal defects, or aortic valve dysfunction. Next is in assessing cardiac function, particularly in the context of systolic and diastolic functions. We need to get the measurements of the following structures during real-time or B mode or brightness mode taken during mid-systole at the maximal opening of the aortic valve. Make sure that the aortic valve is wide open when getting these measurements. Get the measurement of the following: LVOT. LVOT is a segment of the left ventricular outflow tract that extends from the left ventricle to the aortic valve and is situated just below the aortic valve annulus. Next is to measure the aortic annulus. It is a fibrous ring that forms the base of the aortic valve and connects the valve leaflets to the left ventricle. It is located just below the aortic valve leaflets. Be sure to get the measurement at the maximal aortic valve opening in mid-systole. Next is to get the measurement for the sinus of Valsalva. The measurement is taken at the maximal diameter of the sinus of Valsalva, which is typically the area including the bulge before it transitions to the ascending aorta. This is the spot where the aortic wall begins to taper from the enlarged sinuses down to the straighter portion of the ascending aorta. Next is the proximal ascending aorta. The ascending aorta typically appears as a tubular structure that rises from the aortic valve before it arches towards the aortic arch. Also, measurement of anterior and posterior mitral valve leaflets are also important, especially when considering rheumatic heart pathologies. While in parasternal long axis, we must also evaluate the right ventricular inflow and outflow tracts. To visualize the RV inflow tract, we need to tilt the probe tail up. And to evaluate the RV outflow tract, we need to tilt the probe tail down. The parasternal long axis view can also be a window to get M-mode measurements at the level of the left atrium aorta, mitral valve, as well as an LV study. You can also use this view as an additional way to get measurements which can also be correlated with the M-mode measurements at the parasternal short axis view, which will be shown in a little while. M-mode at the aorta left atrium level can measure the aorta, left atrium, to get the LA aorta ratio. We can also get the aortic cusp separation at this level. Aortic cusp separation refers to the distance between the cusp of the aortic valve during systole, which is essential for assessing aortic valve function, particularly in the context of aortic stenosis or regurgitation. Measuring the degree of aortic cusp separation helps evaluate whether the aortic valve opens adequately and can provide insights into pressure gradients across the valve. The M-mode at the mitral valve level can determine the endpoint septal separation, or EPSS. In pediatric patients, endpoint septal separation, or EPSS, is an important echocardiographic measurement used to assess left ventricular systolic function, similar to its use in adults, but the normal ranges can vary based on age and body size. It specifically evaluates the distance between the interventricular septum and the anterior leaflet of the mitral valve or the anterior wall of the left ventricle at end systole. Endpoint septal separation can provide valuable insight into the functional status of the left ventricle, particularly during conditions affecting cardiac contractility. Normal EPSS values are generally less than 7 mm in adults. Values greater than this may indicate impaired left ventricular function. However, normal EPSS in pediatric patients is generally less than 5 mm. However, some specific ranges may apply based on age. In doing M-mode at the level of the left ventricle for left ventricular study, we place the sample volume at the LV level. In getting the measurements, we initially measure the end diastole when the ventricular size is at its maximum volume. Then we get the end systole at the time when the ventricle is at its smallest size. We will be able to get these values taking specific attention to the LVEDD. LVEDD corresponds to the size of the left ventricle at the end of diastole, which is when the ventricle is filled with blood just before it contracts. It reflects the volume status of the heart and its ability to manage preload. Left ventricular ejection fraction, or LVEF, is a crucial measurement used to assess the function of the left ventricle of the heart. It quantifies the percentage of blood that is pumped out of the left ventricle with each heartbeat. Typically, values higher than 55% is considered normal. Values less than 55% may indicate impaired systolic function, while values below 40% are often associated with significant heart dysfunction and may warrant further investigation or treatment. Now we proceed with a parasternal short axis view, or the P-sax. The patient is typically in the left lateral decubitus position, which helps to bring the heart closer to the chest wall for better imaging. Just like in the parasternal long axis view, the echo probe is placed at the left sternal border, usually in the second, third, or fifth intercostal space. We just need to rotate the probe marker to the 12 to 2 o'clock position to visualize the P-sax view. Then we need to tail up gradually to visualize at different planes, namely the aortic plane, the mitral plane, the papillary muscle plane for our LV study, and if indicated, the apical plane if we are considering any pathologies at the apex. With the parasternal short axis view, record real-time or B mode at the level of the great vessels by tilting superiorly, tail down, measuring the following at the mid-systole. Measuring the following, including aortic diameter, RVOT diameter, PV annulus, main pulmonary artery, the right pulmonary artery, and the left pulmonary artery. Coronary arteries can be seen at the parasternal short axis view at the aortic plane. Take note of the location of the left coronary artery, normally arising from the left coronary cusp, while the right coronary artery arises normally from the right coronary cusp. However, there are cases when both coronary arteries arise from a single ostium in the aorta. This anatomical variation is known as single coronary artery or coronary artery anomaly. Measure and identify the coronary arteries seen as to the right proximal and distal coronary arteries and left main coronary artery, left anterior descending coronary artery, and left circumflex. Important to determine the Z-scores, especially in Kawasaki patients, as well as in those considering aneurysmal dilatation of the coronary arteries. Still at the parasternal short axis view at the mitral plane, record real-time the mitral valve opening, taking note of the anterior and posterior mitral valve leaflets, including its mobility and if there are anatomical variations. Afterwards, gradually tail up as we go inferiorly to show the LV at the papillary plane, allowing us to visualize the LV cavity, taking note of the LV shape and geometry, LV wall motion, and contractility. Check for any VSDs. Tilting further until we reach the apical portion to check for any pathology. At this point, we are given a good grasp of the general status of the LV, then later we will proceed to doing the M mode to check for measurements. After getting the real-time videos at the parasternal short axis from the aortic plane, mitral plane, papillary and apical planes, we go back to aortic plane as we proceed with doing the M mode of the aorta LA. As mentioned previously at the parasternal long axis view, measuring the aorta left atrium using M mode can also be done at the parasternal short axis view. Again, aside from the aorta and LA, we can measure the aortic cusp separation as well. This is the distance between the cusp at the aortic valve during systole, which is essential for assessing aortic valve function, particularly in the context of aortic stenosis or regurgitation. Measuring the degree of aortic cusp separation helps evaluate whether the aortic valve opens adequately and can provide insights into pressure gradients across the valve. Get the M mode as well at the RVOT and the RV inflow tract level at this point. At the mitral plane, get the M mode, then we can measure the endpoint septal separation, which, as we have discussed earlier, can also be taken at the parasternal long axis view. As mentioned a while ago, endpoint septal separation is an important echocardiographic measurement used to assess left ventricular systolic function. Again, normal EPSS in pediatric patients is generally less than 5 millimeters. However, some specific ranges may apply based on age. Again, still at parasternal short axis view, now at the papillary plane, measure the M mode. we place the sample volume at the LV level midway between the papillary muscles dividing the LV into half. In getting the measurements, we initially measure the end diastole when the ventricular size is at its maximum volume. Then we get the end systole at the time when the ventricle is at its smallest size. We will be able to get these values taking specific attention to the LVEDD. The LVEDD corresponds to the size of the left ventricle at the end of diastole, which is when the ventricle is filled with blood just before it contracts. It reflects the volume status of the heart as its ability to manage preload. Correlate the LV study done at the parasternal long axis view and the one that is done in the parasternal short axis view. While it is a quick and non-invasive method for measuring dimensions, the M-mode is less comprehensive than the Simpson's method because it estimates LV function primarily through a linear measurement and does not directly calculate volumes nor ejection fraction. Now we proceed with the apical 4-chamber view. The location is usually below the nipple line, but may be at the anterior axillary line depending on the heart condition. The index marker is placed at the 3 o'clock position. Get real-time videos of the 4 chambers. Make sure that the apex is seen in the clips. Measure the tricuspid and mitral valves during diastole when the valves are open. Measure the RV base, RV mid, and the RV length during diastole when the ventricle is at its largest. During this time, you may already get the symptoms at the LV diastole. Next is measure the RA minor and RA major, also LA minor and LA major. Then next is to get the RVFAC, or the right ventricular fractional area change. It is a useful echocardiographic measure to assess the right ventricular function. It quantifies the change in area of the right ventricle from the diastole to systole. To get the RVFAC, we need to get the RV end diastolic area, then RV end systolic area to get the RVFAC. Next, we get the LV ejection fraction by Simpson's method. To get this, we need to trace the end diastolic volume, then trace the end systolic volume to calculate the ejection fraction. Simpson's method is considered an accurate measure of LV volume and ejection fraction because it accounts for the LV's geometric shapes, particularly when considering non-circular shapes. Now we get the TAPSE, or tricuspid annular plane systolic excursion. TAPSE is an echocardiographic measurement used to assess right ventricular function. It specifically measures the longitudinal motion of the tricuspid valve annulus during the cardiac cycle, reflecting the RV's ability to contract effectively. TAPSE is a simple and reproducible measure of RV function, particularly useful in conditions such as heart failure, pulmonary hypertension, and other right heart pathologies. To get the TAPSE, locate the lateral tricuspid valve annulus, ensuring you can see the movement of the annulus towards the apex during systole, then do M mode. Measure the distance the tricuspid annulus moves from the end diastolic position to the end systolic position on the M mode trace. It reflects the amount of upward motion indicating RV systolic function. After TAPSE, we need to get the MAPSE, or the mitral annular plane systolic excursion. MAPSE is a valuable echocardiographic measurement that assesses the systolic excursion of the mitral valve annulus, providing insights into left ventricular function. It provides insight into the systolic function of the left ventricle and is particularly useful in assessing patients with heart failure or other cardiac conditions. MAPSE provides information about the longitudinal function of the left ventricle during systole. It reflects both myocardial contractility and overall heart function. To get the MAPSE, locate the mitral valve annulus at the base of the left ventricle, then do M mode. Position the cursor along the plane of the mitral annulus to capture the motion of the leaflets during the cardiac cycle. Next, we do the apical 5-chamber view. Taking a real-time video of this view can also be done immediately after the 4-chamber view with the index marker at the 3 o'clock position. Then we tilt the probe superiorly with tail down to show the aorta coming from the LV in normal patients with normal positions of the right vessels. Then further tilting superiorly, further tail down to show the main pulmonary artery coming from the right ventricle, again in normal hearts. After getting all the real-time videos and images, we now get the color flow and Doppler studies. Now back to the parasternal long axis view at the 9 to 11 o'clock position. To get the color flow, we need to focus on which area we want to evaluate. A smaller box size means that the ultrasound beam can focus on a smaller area, resulting in improved spatial resolution. This allows for better visualization of finer details in blood flow patterns such as turbulence or subtle changes in velocity. Reducing the box size allows for a higher frame rate because the ultrasound machine has to process less data. A higher frame rate ensures that the motion of blood flow can be captured more accurately, which is crucial for assessing rapid changes in flow dynamics. First, we focus on the LV outflow tract, including the interventricular septum, to check for turbulence in the LVOT, regurgitation, as well as any dropout to check for VSDs. Next, we move the sample volume or the region of interest to the LV inflow tract to check for any turbulence, regurgitation in the LV inflow tract. Still in the parasternal long axis view at the 9 to 11 o'clock position, tilt the probe tail down to show the RV outflow tract, then tail up to show the RV inflow tract. Take note of any turbulence, regurgitation, or even absence of blood flow. Now, proceed to the parasternal short axis view at the 12 to 2 o'clock position. Now starting with the aortic plane to get the color flow. We position the sample volume by portion, dividing the field into 3 fields. First is focusing on the RV outflow tract, taking note of any turbulent flow. Then next, at the middle, focusing on the aorta, taking note of any turbulent flow as well as any dropout, signifying possible ventricular septal defect. This illustration shows the locations of VSDs taken at the parasternal short axis view. At approximately 9 to 11 o'clock position could be a perimembranous type of VSD. Then, from 11 to 2 o'clock position can be a subaortic type of VSD, while beyond 2 o'clock position is a subpulmonic VSD. Others may say that 9 to 12 o'clock is perimembranous type, while beyond 12 o'clock position is an outlet type of VSD. Though depending on the type of VSD, it may be large considering a doubly committed type of VSD. However, we need to evaluate other echocardiographic views before diagnosing such. Going back, we move the sample volume to the RV inflow again to check for any turbulence, regurgitation, or even absence of blood flow along the valve. After the aortic plane, we tilt the probe inferiorly, tail up, to evaluate the mitral plane, to evaluate turbulent flow, movement of the mitral valve leaflets, although not shown in this video. Then tilt further inferiorly, tail up to show the papillary plane, to show any turbulence or even dropout in the interventricular septum, which could possibly be an inlet or a muscular type of VSD. Then further tilt to show the apical plane as well. After getting all the color flow, We now proceed with Doppler studies at the parasternal short-axis view at the aortic plane, placing the Doppler cursor just before the pulmonic valve, then use pulse wave to get the RVOT Vmax by measuring up to the tip and later to measure the pulmonary acceleration time in this way. Pulmonary acceleration time is an important echocardiographic measurement used to assess right ventricular function and pulmonary artery pressure. It reflects the time taken for the blood flow to accelerate from the beginning of the ventricular systole to the peak velocity through the pulmonary valve. Depending on your echo machine setting, it may be seen as a time interval from beginning to the tip, or may be seen like this in the right diagram as a slanted line from the beginning to the tip of the inverted triangle. Next, we move the Doppler cursor just a little after or just below the pulmonary valve, then do pulse wave to get the PV Vmax. PV Vmax refers to the maximum velocity of blood flow across the pulmonary valve. Pulmonary valve Vmax is often assessed in patients with congenital heart defects such as tetralogy of Fallot and acquired heart diseases involving the right side of the heart. It can also be used to monitor diseases, progression, and even response to interventions. We can trace a Doppler signal to get the RVOT VTI. Later, we will need to trace also the LVOT Doppler to get the LVOT VTI. This is important especially in shunt lesions where we need to compute for QPQS. As mentioned, while doing color Doppler, we also need to evaluate any valvular regurgitation like in this echo image showing pulmonary regurgitation. We need to measure it and even do Doppler to check for the gradients. Now, we proceed to the apical 4-chamber view, now to do color flow. Initially, to get a full bird's eye view of the field, then also taking note if there are any ventricular septal dropouts, which could be ventricular septal defects. Then, now focusing on the RV inflow, taking note of any turbulence, regurgitations, then now focusing on the LV inflow tract. Again, taking note of any turbulence or regurgitation. Now we need to do pulse wave at the tricuspid and mitral valve areas to get the EA. E-wave represents early diastolic inflow of blood from the atrium to the ventricle during rapid ventricular filling phase. The A wave corresponds to the atrial contraction and occurs just before the ventricular systole, representing the flow of blood from the atrium to the ventricle. In a healthy heart, the E wave is usually higher than the A wave, with EA ratio greater than 1 during early diastole. This indicates normal diastolic function, where the ventricle fills primarily due to passive flow from the atrium. Reversal of the EA could signify diastolic dysfunction, as in cases of impaired ventricular relaxation. As seen in previous images, we need to measure valvular regurgitations. Take note of the vena contracta, jet area, and the atrial area to get the regurgitant fraction, then get the gradient by using continuous flow Doppler. In getting Doppler studies in valvular regurgitation, make sure you are using it at the time that the valves are closed. Do it in both tricuspid and mitral valve area. Next, still at the apical 4-chamber view, now we do the tissue Doppler imaging, or TDI. TDI is a specialized echocardiographic technique that provides valuable insights into myocardial motion and function. It allows for the assessment of the velocity of myocardial tissue movement, rather than just blood flow, which is typically measured in standard Doppler echocardiography. TDI uses Doppler effects, which measures the change in frequency of ultrasound waves reflected off moving structures. In this case, it measures the motion of cardiac muscle tissues. TDI provides quantitative data on peak velocities of myocardial motion, allowing for the assessment of both global and regional myocardial function. To do this, place the sample volume at the medial mitral valve annulus, then use pulse wave and TDI. Identify the waves, namely S, E, and A waves as follows. The S wave or systolic wave is the highest peak during the ejection phase, reflecting systolic function. The E wave or the early diastolic wave is the peak during the early diastolic filling phase, indicating diastolic relaxation, while the A wave or the late diastolic wave is the subsequent peak associated with atrial contraction. Do the same thing at the lateral septum at the mitral valve annulus and measure. Get the S, E, and A waves. Now, doing the apical 5-chamber view, showing the LV outflow tract and aorta. Now place a Doppler cursor at the LV outflow tract, then do pulse wave to get the LVOT Vmax. Now, we can trace the LVOT Doppler to get the VTI. A while ago, we traced the RVOT VTI to later compute for the QPQS. Next, we move the Doppler cursor to the aorta to use continuous wave to get the AV Vmax. Also, we can trace for the VTI. Next is to get the isovolumic relaxation time, or the IVRT. The IVRT is an important parameter in echocardiography that measures the duration of the isovolumic relaxation phase of the cardiac cycle. This phase occurs after the closure of the aortic valve and before the opening of the mitral valve, during which the ventricles relax but do not change the volume because all the heart valves are closed. IVRT is defined as the time interval from the closure of the aortic valve to the opening of the mitral valve. During this period, the ventricles are relaxing, but the volume remains constant because the valves are closed. Next is the apical 2-chamber view. Apical 2-chamber view enables us to detect abnormalities in regional wall motion in the visible segments, as well as estimating global left ventricular function. It is another way to evaluate mitral valve as well as left atrium and left ventricular sizes, wall motion, and pathologies. This view allows visualization of the anterior and inferior walls of the left ventricle as well as the coronary sinus. To do the 2-chamber view, coming from the apical 4-chamber view, with index marker at the 3 o'clock position, gradually rotate the index marker to approximately the 12 o'clock position. In this view, we can measure the LA sizes and area. The 3-chamber view can further evaluate the LVOT, including problems in the aorta and aortic valve. It is good in assessing LVOT obstruction. To do the 3-chamber view, rotate the index marker to approximately at the 11 o'clock position. Now we proceed to the suprasternal long axis view. This may be very uncomfortable to most patients. To do this, we ask the patient to extend their head and to look to the left side to accommodate the probe. Place the probe in the suprasternal notch at the approximately 1 o'clock position with tail of the probe towards the patient's right ear. However, some patients may have right-sided arch. In that case, we may place the probe at around 11 o'clock position. Make sure to see the image of a candy cane with 3 major arch branches, namely the brachiocephalic trunk or the innominate artery. Next is the left common carotid artery, and the third is a left subclavian artery. In this view, you can also see the cross-section of the right pulmonary artery. In this view, do the color flow to check for any turbulence, regurgitation, or even tapered or interrupted flow across the aorta, and the major arch branches. Do Doppler studies using pulse wave and measure the results. Next is the suprasternal short axis view. Adjusting the probe to approximately 3 o'clock position to see coronal section of the left atrium, also to check the entrance of the 4 pulmonary veins to the left atrium. This is also called the crab view. In this view, we can also evaluate the right pulmonary artery and the left pulmonary artery as an additional view if we are having a hard time interrogating the PAs in the parasternal short axis view. Previously, I mentioned on the VSD locations at the aortic plane. Now, this illustration shows you the other locations of the VSDs, and these other views are the other areas to interrogate if considering ventricular septal defects. In general, you can devise your own strategy in doing 2D echocardiogram. Suffice for me to say that we need to be systematic in doing the procedure, whether we start with a subcostal view or parasternal long axis view, depending on which is feasible. You can create your own style in performing the echo as long as you arrive at a diagnosis that will best manage your patient. Thank you very much for your time. Again, this is Dr. Kristian Rubiano. Have a great and awesome day ahead.